Podcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the We Can educational series. Today, Dr. Angela Rabbitt and Dr. Jim Anderst will discuss protocolized assessment of child maltreatment. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log into your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
Good afternoon. My name is Dr. Angela Rabbitt. I'm one of the child abuse pediatricians with Child Advocacy and Protection Services at the Medical College of Wisconsin. And as many of you know, our team does the medical evaluation when children present to the Children's Wisconsin system for suspected physical or sexual abuse or neglect. Recently, Children's Wisconsin has been working to improve its system of care for patients with child maltreatment concerns. Our team, the CAPS team, has also received a number of requests from the community recently for some evidence-based guidelines for mandated reporters when child maltreatment is suspected. So we wanted to take this opportunity to introduce a new process we're developing within Children's Wisconsin, and then also to introduce a resource that we feel could be helpful for mandated reporters and investigators outside our institution who are looking for some evidence-based guidance on the response to maltreatment. The processes and tools we'll talk about today are examples of physical exam-based protocols for decision-making. As we learn more about the biases that can sometimes sneak into assessments for child maltreatment, more and more institutions are moving towards more protocol-based screening as a way to remove some of those biases from decision-making. So today we've asked one of our colleagues from Children's Mercy Hospital in Kansas City, Dr. Jim Anderst, who's a professor with the University of Missouri Kansas City School of Medicine, to talk to us a bit about the reasons and the benefits of physical exam-based protocols, and also to introduce the Child Protector app as an example that can be used by investigators and mandated reporters. So last week you should have received an email with some instructions to download the app if you want to take a look at it during the presentation. And also Dr. Anderst will, when he presents his part of the presentation, he'll kind of give you some tips on how to find it as well. And I will take the opportunity to provide an update on Children's Wisconsin and the Medical College's new protocolized systems review process that we're creating. So with that, I'll turn it over to Dr. Anderst to start, and neither of us have any conflicts of interest to disclose.
Okay, thank you, Angie. As Angie mentioned, I'm a child abuse pediatrician in Kansas City, Missouri. I would be the equivalent of Angie or Dr. Sheets or any of your team up there in Milwaukee. What Angie didn't mention is that I was born and raised in Wisconsin. I'm from Manitowoc and spent my entire childhood there. And life took me elsewhere, and now I'm in Kansas City. But it is nice to engage.
I don't think I knew that.
Yeah. It is nice to engage with those of you from Wisconsin virtually today. And so I'm going to talk a little bit about how people think in child abuse and how we solve problems in child abuse. And then, as Angie mentioned, I'm going to talk about the app. If you're interested in downloading the app now, because it'll be useful later, if you have an Android phone or an Apple phone, it's free, and you can go to the stores on either of those, and if you simply type in Child Protector, 2 different words, it should be the first or second one that shows up. And it takes a moment or two to download, but feel free to do that now while I'm talking about these other things, because it'll take a couple of seconds to download. But before we get into that, the attendees, most of you deal with child abuse from a child protection, a child welfare, a medical, or a legal perspective. And if you think about how you make decisions in child abuse, and really this can be applied to most anything in our world, we have simple problems and we have complex problems. A simple problem for a social worker might be somebody needs transportation home from the hospital. And there's only a couple ways you can do that. You can get a bus pass or a taxi, and there's only so many ways to provide that. It's a simple problem. But most of what makes us unique in our tasks is our ability to solve complex problems that we can uniquely do that somebody else who isn't trained the way we are, they can't do. And when applying that to child abuse, when we think about how a problem is structured, they can be complex, they can be simple, and they can be dynamic or static. And if you're getting information that changes, it's dynamic. If it's just one set of information, it's static. And then one applies their skills, and then they make an assessment. And you want this to be consistent over time so that if you're presented with the same set of information, the same variables in two different settings, you process it the same and give the same answer. That, when you do that, eliminates bias and it eliminates variability on what you're doing. And so we're going to go through some of these concepts little by little just to sort of frame why the app was created. If you can go to the next slide. So child abuse in and of itself is an ill-structured problem. There's many alternative solutions. You can have somebody harm the child. You could also have different types of accidents. You can have medical conditions. And so there's different paths to solve it. You can solve it by accessing different information from people and their history. You can look at the child. You can get history from the child in some places. Sometimes it's the environment around the child, the home they're in, for instance, in a burn. All of this plays a role in the problem itself. And so it's very ill-structured. And there's different ways to approach it. And ill-structured problems are hard to solve. It's very different than somebody who comes in and says, I have pain in my ear and I have a fever. And most people will immediately conclude that an ear infection is high on the list. That is a much simpler medical problem than child abuse. Next slide. It's also complex. One has to sort through a lot of different information and decide which information is important and useful and which information is not important and useful. And this is really true for any of us in the child welfare system, in the medical system, in dealing with child abuse. You're hit with a bunch of information, and you have to figure out which information you're going to use and not use, and how you're going to prioritize that. Next slide, please. And then it's dynamic. You can be going through the process of deciding what to do in a case of possible child abuse, and then all of a sudden the information you get changes, or you get new information, or some of the information you thought that was true is actually false. And so you have to adapt your thinking on the fly. And when you get new information, that interacts with the information you already have. And this is very different. You can see how something that is ill-structured and complex and dynamic is much, much harder to deal with than a simple problem where the answer is straightforward and there's only so many different ways one can think about it. And it makes child abuse particularly difficult because it is one of the most complex and ill-structured problems with a lot of dynamic information. Next slide. So when we think about this and we put it together, what we wanted to do with the Child Protector app, and we'll go through it later on, is to take this process and simplify it and take some of these skills that an expert in child abuse uses and put at least some preliminary ways of thinking into the app. The app doesn't solve the problem or give you a diagnosis, but it certainly helps provide a structure and point someone in the right direction. And when we go through the app, we'll go through specific problems, specific cases, and you'll see how it takes something that's ill-structured and complex and dynamic and processes it into something that's well-structured, simpler, and more static, so that it can be consumed and handled more easily over time. And the end goal is to be more consistent and make appropriate decisions that benefit the child and family and society in general. So what does an expert do? And again, this isn't just doctors, this is law enforcement officers, attorneys, social workers, anyone in child welfare, forensic interviewers. You have to figure out what's important and what's not, and you have to know how to get it. And you have to know how to weigh that information. That's the content knowledge. And you have to be able to pick it up quickly. So in other words, if you gather a bunch of information and then somebody gives you new information, you have to be able to rapidly sort the information in your head that you've already gathered and apply that new information to that old information. That's what an expert does. We do things without even thinking about them because it's so ingrained in our head. And we have to be very flexible about how we do it. And if you think about that, and if you have a spouse or somebody else in your life who doesn't do what you do may seem very complex to them, or what they do may seem very complex to you, but that's because we have different expertise. Next slide. And so when thinking about this, folding this information in the app, we wanted to look at cognitive errors or errors in thought in abuse. And so we did some research around this. It's been well known that there are cognitive errors in abuse, and we wanted to drill down a little bit to look at where the errors were from a medical perspective. So how do we make decisions in determining if injuries are due to abuse or an accident? And what is your cognitive approach as you approach that evaluation of a child with injuries? And really, all of us do this: medical providers, child protection system, legal system. We all have to process this information. And it's useful to think about why you're doing what you're doing and why you think what you think. And that's how you can diagnose your own cognitive process and see if you have any biases or errors. It's important to have a process or a functioning cognitive framework, and that's knowing why you think what you think so that the process can be repetitive over time and you come to the same answer given the same set of information. We want to do this to reduce bias, to be able to separate useful from not useful information, and to prioritize and order that information. We do this in our own work, each of us, seamlessly, because we each have expertise. But child abuse, it's hardest to do it in this because of the nature of the problem. It's so complex and so dynamic that even if you have expertise in it, it's easy to make errors. So one of the ways we looked at this is if most fields use simulation in some way, shape, or form. In medicine, we have patient simulation, where you have a patient who comes in and a learner asks the simulated the person who's an actor, what's wrong with you? Why are you here? And the actor gives symptoms, and they tell their history, and the person that the learner does an exam, and they have to figure out what's wrong with the simulated patient. We can do this with child abuse too, where we have a mannequin is the child and has maybe marks or bruises, and the parent is a real live human who's an actor. And we created cases to test physicians and nurse practitioners regarding their accuracy and diagnostics, and also figure out if they were making errors, where were the errors, what was the source of the errors. And so we used 43 subjects. These are all physicians and nurse practitioners, and we had 8 cases of a child with a fracture. It's a simulated fracture. So a kid comes in with a fracture, and the parent has a history of how it may or may not have happened. You get an X-ray, you get some social history, and the learner, the doctor or nurse practitioner, would have to give their diagnosis and talk about why they made that diagnosis. Half of these 8 cases, the correct answer was abuse, and half it was accident. So that's just kind of what we were doing in this study. And again, the point was to figure out when people made errors, why did they make that error and where was the error? So again, the subjects were medical professionals, physicians, nurse practitioners. They were given an X-ray and a written social history. They could go in and interview the parent, examine the mannequin child. They could order further testing if they wanted a CAT scan or blood tests or whatever, and we would give them the results. They would document their diagnosis. And then if you've ever done simulation, there's structured debriefing, meaning we talk to them in detail about their decision making and why they made specific decisions. And that was the process that all 43 of these participants engaged in. And so these were the X-rays that were used. Again, half of the cases were abuse, half were accident. And each of these X-rays, these are 2 different X-rays, 2 completely different cases. The one on the left of your screen, there's a black arrow pointing. Yeah, Angie's got it there. There's what's called a buccal fracture, and that happens a certain way. We would call it an axial load, or if like someone landed on their knee, that's how you could get that fracture. Now that could be an accidental fracture or an abusive fracture. It really matters on the history provided and any other findings in the case. The other fracture is for a different set of cases, and that would be an oblique or a spiral fracture. And that can be an accidental twist where the child is running and falling, or someone can grab the child's leg and twist it and cause the fracture. Again, it depends on the history. And so each of these X-rays was used in 4 cases, and for each X-ray, half of the cases were abuse and half were accident. And they were mixed and matched randomly for the subjects. So what did we find? 37% of the subjects provided an incorrect diagnosis regarding abuse, meaning they had everything they needed at their fingertips to come to the right answer, and they got it wrong about 40% of the time. When we think about how you come to a correct diagnosis in abuse, you have to know what you're looking at with the X-ray. And almost 60% of the subjects, these are fully trained physicians and nurse practitioners, did not correctly identify the fracture morphology or the shape of the fracture. And the reason you have to identify the shape is because if you know the shape, you can tell how the fracture happened. And 60% of those got the mechanics correct. So I'm sorry, 58% correctly identified the fracture morphology, 60% correctly identified the mechanics. But that means about 40% of them got it wrong. Now you'll note that 40% got the case wrong. The 40% who got the X-rays wrong are not the 40% necessarily who got the case wrong. And so they might get the X-ray wrong, but still get the case right, or get the X-ray right, but get the case wrong. Many of the people falsely believed that the history that they were being given had changed when it hadn't. And many of them falsely believed that the mechanics didn't fit the injury, meaning they weren't applying what they saw in the X-ray to the history appropriately. And these are sources of error. We were whittling down to where the errors were being made. So that study basically told us that physicians and nurse practitioners make errors around child abuse, and they make them and they don't even know they're making them. And sometimes they get the right answer for the wrong reason, and sometimes they get the wrong answer even though they did all the thought process right. If you look at what this means, how this translates to children, this study, which we actually did earlier, compared the diagnosis of child abuse pediatricians to non-child abuse physicians on the same exact cases. And so we wanted to characterize the differences in diagnosis when Children's Protective Services consults physicians with expertise in child maltreatment. And so this is all busy, but the stuff that's important is at the bottom. 40% of the time, the child abuse doctors did not agree in diagnosis with the non-child abuse doctors. When they disagreed, 80% of the time, the child abuse doctor was less concerned about abuse. So anyone who asserts that child abuse doctors just say things are abuse, that's actually factually incorrect. And there's another study done in Connecticut that has very similar results that show that child abuse doctors are generally speaking less likely to diagnose abuse in the same cases as non-child abuse doctors. And when there were differences in diagnosis, the reason behind it in many cases was that the child abuse doctors got more information from CPS. And this really highlights the critical nature of multidisciplinary work in this field. The child abuse doctors would reach out to CPS, get more information, somebody they couldn't talk to, something from the scene that changed the diagnosis that the other set of doctors, the non-child abuse doctors, they didn't access or have access to. And so, the points of this, child abuse doctors are less likely to diagnose abuse, and that relationship, that exchange of information with CPS is absolutely critical to getting the right answer. So the takeaway points from these two studies, and again, put this in the framework of what we talked about at the beginning, that diagnosing child abuse, evaluating it, is a complex and dynamic process that requires expertise. And if you don't do it regularly and you don't know how to order your thoughts, you're going to make errors. And what we found looking at the simulation study and sort of applying it to the real world is that medical providers often do not have a cognitive framework when evaluating abuse. They might get the wrong answer, but have done everything right, or they might get the right answer and for the wrong reasons. Correct answers are often achieved by mistake, and that's not what you want. And so this is why we have to have referral to child abuse experts who are often less likely to diagnose abuse, but more likely to access external information from people like CPS. When applying this to primary care doctors, this was a great study. It was done, oh gosh, over 10 years ago now, where the whole point of this is they asked child abuse, they asked primary care physicians about cases of abuse and their likelihood to report given certain scenarios. And what they found was really fascinating, but it's kind of stuff we know. Doctors generally don't trust the child protection system. for one reason or another. I don't think it's necessarily a valid situation, but that's the way a lot of them approach it. And that has to do with a lack of familiarity or an idea that they can handle whatever went on without calling CPS. And it creates all sorts of problems for children and the child welfare system downstream. And it also has to do with pediatricians and other doctors just not being well prepared to handle child abuse in their office. And what we really have to do when we think about this is that the evaluation of abuse is based on tangible data. The social structure is incredibly important for looking at placement in the home, how to help the family, thinking of safety for the child in the future. But it's not helpful in deciding if something is accidental or abusive. Social risks or the absence of risks is not part of the diagnostic process. A risk factor is not useful in deciding what actually happened. It's simply a risk factor. And we have to separate emotions and relationships. And this is something that's really hard, I think, for general pediatricians and primary care doctors. They know these families. And it's a little harder when you know somebody and you know a parent to think about abuse, to think about that might have happened. And so people have to separate that out. And that is the exact opposite of the way physicians are trained. And that's why it becomes really hard for primary care doctors to handle this well. And so the best thing really is to use a protocol based on physical findings. A bruise in a 2-month-old is concerning for abuse. It doesn't matter how nice the family is. And so those sorts of policies can keep people framed on data and actual evidence and science, as opposed to the things that generate bias.
Great. So I'll take over now for a minute and talk about Children's Wisconsin's child maltreatment system review process that we're developing. Children's is aware of these potential biases that are increasingly being discussed throughout the literature. And we've also become more aware recently that other specialties within our institution outside of the Child Advocacy and Protection Services program don't have a real firm grasp on what happens once child maltreatment concerns are identified within the institution, what that process is. And there's a lot of interest in learning more about that within the institution. Having a better understanding of what that process is really important to improving medical decision making. For example, if a provider has a preconceived idea of how CPS will react to a given situation, whether that perception is right or wrong, that can impact decisions to pursue a physical abuse evaluation and can impact mandated reporting decisions. But most providers outside of the CAPS program don't ever really get to see how a case plays out. They don't see the kind of the bottom of the iceberg. So as an institution, we're developing a systems review process that will allow a more in-depth look at our response to child maltreatment as a system. This process is right now being developed and is a collaborative effort between Children's Wisconsin leadership, the Child Advocacy and Protection Services program, Children's Quality Improvement Department, and the emergency department is taking a leadership role on this with us, because really the majority of hospital-based cases come through our emergency department first. We've been developing this process over the last several months and are getting ready to move into the pilot stage, where the process will be further refined. So what I'll share with you is a high-level look, kind of a review of the process without much detail, because those details may change over time. The goal of the system review process is to standardize and improve the response to child maltreatment throughout the Children's Wisconsin system. We're hoping to collect quality and outcomes data that will inform systems improvement, and also to improve communication within our system regarding the medical, community, and investigative process when patients present with child maltreatment concerns. Our first step was to create an algorithm to guide medical testing and mandated reporting decisions. The algorithm that we've created with the emergency medicine department is now being piloted in the ED. It targets children less than 48 months of age, because this age group is pre-verbal or minimally verbal. They're usually unable to tell people what happened to them, and so are at higher risk of kind of falling through the cracks. A child enters the algorithm if they have an injury that based on the best research we have, is considered to be associated with abuse, even if the provider does not feel the injury is concerning. So to be clear, not all of the children who will be reviewed through the system will be reported to CPS and law enforcement. The decision to review is based on the injury, not the concern for abuse. So that essentially takes the bias out of the equation. If the provider is concerned for abuse or has questions about the evaluation, they'll place a consult to our team, the CAPS team as usual. If they don't have concerns for maltreatment, they place a notification in the electronic medical record, which triggers the review. Both of those choices will trigger a review by our team and the larger systems review. The emergency medicine providers also inform the caregivers, unless it's not safe to do so, that the child has an injury that per protocol will get a second look through the systems review process. Other children who don't fall into this algorithm will be reviewed if social work consults our team, if the reason for the visit is physical abuse or someone has diagnosed abuse in the medical record, if CPS or law enforcement are involved, if a provider starts an evaluation for physical abuse, or if the case was assessed by our team at the request of investigators or attorneys. But case reviews on children who were not seen within the Children's Wisconsin system for the abuse concern are excluded from that. They won't be reviewed because they're not patients of our institution. And any provider or staff can also submit a case for system review. Also, if someone submits a safety event involving child maltreatment concerns, those cases will be reviewed. Safety events are filed by employees if they feel that something happened within the organization that could endanger the child's safety. We'll be collecting information about the initial and subsequent evaluation, like what injuries the child presented with, and then were there any additional injuries found on further screening for abuse. The algorithm provides a guideline for what evaluation is recommended based on current research. However, at times there will be reasons to deviate from the guidelines, and there also can often be barriers that make the guidelines difficult to follow. So we want to know about that to see if any additional education or systems changes are needed to help providers follow best practice, or maybe it's that the guidelines should be changed. So those are things we want to take a look at. We'll also look at what additional actions were taken by the CAPS team after we review the case, and if there are changes to opinions about abuse likelihood based on that expert review and further investigation. We also hope to create a better response to parent grievances. And as you all know, sometimes those are unavoidable just because of the nature of what we do. But if there is something that we can do to make it easier for families that are going through this process, we want to make sure we're working towards that. Finally, we'll take a look at the outcome of the investigation if possible. And this would be like substantiation decisions and actions in criminal court. Though we realize we often won't have that access to this information, especially outside of Milwaukee County, and we have to work within the boundaries of confidentiality. So this data will be compiled by the Quality Improvement Department. The plan is that at monthly meetings, overall trends will be reviewed. If there are any cases that need further information or discussion, that will be done at these meetings. The review team will be comprised of a core group, which includes representatives from our team, the CAPS team, emergency medicine, risk management, the quality improvement team, and social work. Representatives from other sections and specialties will also be brought in as needed, depending on the case being discussed. So the ultimate goal of these discussions will be to improve the Children's Wisconsin system. During the initial pilot stage, and probably even after, there'll be ongoing refinement of the process. So I think this protocol-based system review will do a lot to improve providers' knowledge of child maltreatment best practice responses, and also of the broader system that works to improve safety for children. This process is specifically focused on Children's Wisconsin. But as I mentioned, many providers and mandated reporters, as well as investigators outside of Children's, have often expressed an interest in an evidence-based decision tool for potential physical abuse cases. So I'm going to turn the presentation back over to Jim in just a minute to discuss the Child Protector app. But before I do that, I want to pause here and answer any questions you might have either for Jim or for me.
No questions.
No questions. Okay. We will move on then.
Okay, thank you, Angie. So the rest of the presentation is going to talk about the Child Protector app. Again, it's free in the Google Play or App Store on your iPhone. So if you joined late, you can go into either of those and type in Child Protector, 2 words, and this should be the first or second thing you get. And like I said, it's free. We want people to use this. It's not something we're making money off of. The point of this, thinking back to the beginning of the presentation, is to sort of impart some of that expert decision making into the hands of anybody who has an iPhone who does these cases. We want it to facilitate and encourage communication between MD team members. We want people using this to say, hey, doctor, I'm the CPS worker. I looked up oblique fractures of the humerus on this app. Talk to me about it, because that's what this X-ray says. We wanted to assist people in investigations so that investigators can ask better questions if they understand how an injury could have occurred, both accidentally or abusively. I think investigators can ask better questions of the potential suspects or people involved. We want to reduce bias. We want people to use actual data and evidence in their decision making. And then improve consistent application of recommendations in medical care. You'll see when we go through the app, there are inputs and there are outputs, and there's a whole mess of a decision tree behind each one of these, and it took quite a bit of time to develop, but each output is tailored to the inputs provided. So today, the Child Protector, the goal is to help provide some of that cognitive framework we talked about. We need to understand the relationship between a child's developmental capabilities, the injury they have, and I have written biomechanics of injuries, but that's just basically the forces or how the injury could have happened. And when you get a history of how it may have happened, does that make sense given the injury the child has, the fit of the mechanism to the injury? So Child Protector, the screenshots you see are from the app. We like to call the little guy Chucky because he looks like Chucky from the movies. And Chucky has all sorts of stuff done to him. He breaks his leg, he gets his arms hurt, he has bad things happen, but Chucky's really resilient and he will still be there every time you open the app. We received funding from the Children's Justice Acts of Texas and Missouri. Again, it's free, and I hope you've downloaded it. The other things on this besides Chucky and injuries are x-rays, descriptions, videos of medical findings and how they could have occurred, and also decision trees, and we'll go through some of those in detail in a couple of cases. So the decision trees embedded within the app impart things like how and where the injury could have happened, what the injury is like, what may have caused it, and are there any other injuries, and then characteristics of the child and care environment, the mobility of the child, the age of the child, or the siblings. These are all things that are in the app. And we think about that content expertise of getting large amounts of information and ordering it and using it in your decision making. A lot of that is built into the app. There are also recommendations that get sort of spat out at you. And when you use the decision-making trees, they will tell you, you need to obtain further history and then provide a link to the sorts of questions you should be asking. The other recommendations might be take photos of the scene, or get an interview of the child, or obtain a medical evaluation for children. Or if you're in the hospital, to get a skeletal survey, or all the x-rays of the bones. It's designed for use simultaneously by either investigative personnel or medical personnel, and the recommendations overlap because we should be working together on these. There's animation. So for instance, if you're an attorney and you get a case put in front of you and a child is being seen for a liver laceration and a buccal fracture of the distal femur, and you want to know what all that means, you can actually load up animations that come in the app, and there's a person talking to you, and you go inside of Chucky's body and you learn what these injuries are and how they could have happened. And I encourage you after this session, if you've downloaded the app, just play around with the videos in there. Everything from head injury, abdominal injury, burns, bruises, and fractures are all included within the animations. So here are a couple of case examples. And if you have the app, there's going to be parts where we actually load up the information into the app. And so you can see how it works. So here's our first case. 2-month-old baby is at daycare, and the following is noted during a diaper change. And that following will be coming up here. It's going to be some bruises. CPS was called and recommended that the child go to the primary care doctor. When the family brought the child to daycare, they didn't mention anything at drop-off. They didn't know about any injuries. The child was otherwise well, no fevers or congestion. Had some noisy breathing and a little bit of cough, but that was pretty normal for a 2-month-old, and no rashes or any other skin problems. And so here you can see on the physical exam, there are the nice arrows pointing to marks on the back. And if you know much about child skin, these are the sorts of things that could be bruises, or they could be what people call dermal melanosis, or other people refer to them as Mongolian spots, and that kids are born with and they fade over time. These kind of look like bruises in that they're brown, or at least some of them do, and that's not usually the way those dermal melanosis marks are. But the child is otherwise well appearing, has a normal abdominal exam, and has what appears to be bruising to his back and buttocks, and a normal neurologic exam. In other words, he's awake and alert the way a 2-month-old would be. There's no history of trauma, no drops or falls or other known issues. Developmentally, the child is appropriate, meaning he smiles, he coos, he can't roll over, he can't crawl, he certainly can't stand up. No other history of any other injuries. He received vitamin K at birth. If you're not in medicine, that's important, because if you don't get vitamin K, you're at risk of bleeding and bruising later on. He received his 2-month vaccines a week ago, and there's no medical history in the family of anything that would suggest a bleeding disorder. And he has a 2-year-old sibling at home. So if you are in the Child Protector app, it doesn't matter whether in your medical provider or the law enforcement or worker section. If you open it up and go ahead to the next slide, there is a table of contents, and you can scroll across the top of the screen, and there's words describing each of the pictures: fractures, head injury, bruises, abdominal injury, history taking, and burns. And of course, in this case, we have bruises, so you'd want to go to the bruise section and tap on that with your finger. And when you tap on that, this is the table of contents. This is what the image actually looks like. You're going to want to hit the one that says Forensic Decision-Making Tools under Bruises. And so then you will get this series of questions. And the first one is, where is the area of concern, or where is the bruise? And on this child, it's the back and the buttocks. And then there are a series of characteristics of the findings. And in this case, it's bruising in an immobile infant. Is the child walking or non-walking? So this would be a pre-mobile child. One of the nice things about the app is it's got different things embedded. So those little eyes on the right, if you click on them, it takes you to some information regarding child development and normal child development. So if you're trying to remember what age does a child roll over usually, or at what age does a child pull to stand, there's actually information in the app that you can jump to that will tell you that. And then you can seamlessly flip back to this screen and continue input regarding the case. And so if you enter all the information into this decision trees, you'll enter in the areas of concern that we talked about: the bruising in an immobile infant, that the child is pre-mobile, otherwise is normal, the child's not unconscious or neurologically abnormal. What's the cause? Nobody knows. So you would click on that one. It's unknown or other. How old is the child? And this child's, of course, less than 6 months of age. Are there multiple other significant internal injuries or burns? Not that we know of at this point, so the answer is no. Are there siblings or other children in the same home? Yes. And if you don't have the app downloaded, these are the questions that are basically asked of you in the app. This is the information you put in. Next slide. And so when you hit submit for bruises, it spits this out at you. And it tells you that there's a high likelihood of abuse in this case, and there are next steps recommended. If you're on the scene, or if you're where the child stays at home, to take photos, obtain further history of injury mechanism if there is one, If you need a forensic medical exam of the sibling, you need one of those. The sibling needs to be seen. And if you were to hit that eye next to that, it actually links to the American Academy of Pediatrics webpage that links to all of the places where you can find a child abuse pediatrician in each state. And so if you clicked on that, you could actually find the good folks in Milwaukee and whatever they can provide for other places in their state where this sort of evaluation is available. You'd also want to have an immediate safety plan for the child. This child is at high risk of abuse and shouldn't go home without a safety plan and needs a medical evaluation. Just moving over to the slide on the right, there are medical recommendations. This child needs a skeletal survey, needs blood testing for liver function tests, and needs imaging of the head and spine. And these would be the things that are really helpful to the medical team. And if you have a doctor who says, why do I have to get liver function tests in this kid? If you click on that eye, it takes you to an animation that explains why one would need liver function tests in this patient. And so it's got some other recommendations too, but you can get the idea. You put in a set of inputs and it gives you a set of outputs of actions based on the information. This isn't the ultimate answer. Notice it doesn't say diagnosis of abuse, it says high likelihood of abuse. This is an initial big arrow pointing you in a specific direction and also giving recommendations to the medical providers regarding what tests should be done. Those medical recommendations are most useful when, for instance, a CPS worker gets called out to a smaller town or a rural hospital where they don't have a child protection team or a pediatric emergency room, where they're really unfamiliar with this sort of stuff. And the medical recommendations can provide a real clear guidepost for what needs to be done for this child now, at this moment, no matter where the child is. Occult trauma is trauma we can't see with our eyes, meaning young children, particularly abused children, can have broken bones, they can have internal injuries that you cannot tell by doing a physical exam. And there are animations within the app that will take you through why somebody needs a skeletal survey or an x-ray of all the bones using animations and using Chucky. Stuff happens to him. And it explains the rationale for it. So if you get the grumpy doctor at 2 in the morning at a small town hospital and he doesn't want to do it because it's going to take too much time, you could actually show that person the app, and if they're willing to look at it, that would explain to them exactly why a skeletal survey is needed. On this child, in our case, our 2-month-old, the skeletal survey showed multiple acute rib fractures. If you look closely, there's green arrows pointing to them. I don't expect non-medical personnel to really be able to discern it well, but that's why somebody goes to be a radiologist, because they can pick these out. But you can see there's little broken bones, little black marks in the ribs that are broken ribs. And then there's abdominal trauma. That is a picture. What you're looking at on the picture of the app is a CAT scan. And so the child's feet would be coming out at you, and their head would be going into the screen. So the child's on his back. And what you're seeing are yellow arrows pointing to blood and cuts within the liver. And that's a liver laceration. And the nice thing about the app is it explains all of this in non-medical terminology to somebody who's trying to decipher all this medical mumbo jumbo. And in this kid, we did the testing for liver and pancreatic enzymes, and those were normal. And so this child did not need a CAT scan of the abdomen. But the information in the app goes through the why behind all of that. And then head trauma. You can have kids who have bleeding on their brain, but they otherwise look normal. And in the app, on those outputs, you can hit the eye, and it takes you to the occult trauma screening, and it explains why kids need CAT scans or MRIs of their head, and under which circumstances. And in this child, there was what are termed subdural and subarachnoid hemorrhages. They're hard to see. This is what's called a coronal MRI of the brain. But this kid, again, wasn't vomiting, wasn't having seizures, was otherwise well, but the scans, and Dr. Rabbitt's pointing to the blood, showed bleeding on the brain in 2 different layers. And the only way we find that is if we follow the appropriate evidence-based recommendations. And in a 2-month-old with bruising, you need to scan their head, and the app provides that information. And so this child also needs an eye exam for retinal hemorrhages now that we found blood on the brain. And so there's also lots of educational content. Remember when we entered into the bruising and skin injuries area, we went to the forensic decision-making tools. If you go back to bruising and skin injuries, there's a whole library of content, if you click the button beneath it, that goes through different kinds of injuries and how they happen in children, and actually what the anatomy is of the injury. If you're trying to understand the difference between a subdural hemorrhage and a subarachnoid hemorrhage, and you're an attorney and you're getting ready for court, or you just want to know what this means for your own work as an investigator, there are animations and narrated sequences that walk through all of this in a non-medical friendly way. So there are videos and photos that go through just about everything you could encounter. I don't want to say everything, but most things you could encounter in physical abuse in children. There's a sequence on dating bruises, and if you work closely with the child abuse doctors, you will know that we cannot accurately date bruises, but there's actually an animation on why we cannot date bruises, and there's a person explaining to you that. There's also bruises by body parts, so you can have a child who has ear bruising, and you can go to the animation and learn how kids can get ear bruising. You can go to the animations and learn how children can get buttock bruising, both accidentally, well, it's usually inflicted, but say chest bruising, accidentally or inflicted. And so that's the benefit of the animations and narrations. You can see what happens to Chucky and see how he could get injured in different ways, both from an abusive means and an accidental means. And when you have that knowledge, you can ask better questions. So putting in, remember this child had a 2-year-old sibling, and this child was seen and had bruising on his forehead and shins. And if you know much about 2-year-olds, it's not an unusual thing for them. There was no characteristics that were unusual about the findings. He walks independently. The reported history is that he fell while running. He's 2 to 5 years of age. There's no other significant injuries. And are there siblings? Yes, but that sibling was the 2-month-old with the bruising. And so if you input that, this is our sibling we're putting into the app now, you get a different set of outputs. And so this is most likely accidental. So the injuries in the 2-year-old sibling are generally going to be an accident. It's very common for kids that age who are mobile to get bruises on their forehead. And you can see the outputs are very different for this child than there were a 2-month-old, and that's because the inputs are different. And child protectors, like anything, if you learned anything about computer programming like me in the 80s, it was garbage in, garbage out. And if you put the wrong stuff in, you're going to get bad stuff out. Just a word about sibling evaluations. It's important to know that when one child is abused, other kids in the home are at high risk. For instance, in twins, when one is abused, the other's abused greater than 20% of the time. When a child is abused, greater than 50% of families may have another child abused in the future. And 10% of siblings or so have occult or hidden fractures. And that's why it's important when there are siblings, particularly young siblings, they get evaluated too. Our policy here in Kansas City, and I'm going to guess it's pretty similar in Milwaukee, is that siblings less than 5 years of age, we see all of them in cases where we are highly suspicious or concerned for abuse in the primary kid. And the app uses this in its decision-making processes.
And that's the same here.
Yep. Okay, one more case before we wrap up, and this one's having to do with head injuries. And so here we have a 16-month-old girl who stopped breathing at home. Mom left for work at 6 a.m. The child was healthy at the time. Mom's boyfriend was caring for the baby while mom worked. I'm sure we've all heard that story before. Text messages from the boyfriend to mom were that the baby was breathing funny and she wasn't responding. So mom tells the boyfriend to call 911 and EMS arrived. And the child was brought into the emergency department 1 hour after the first text message. So the child comes in, a GCSF5, meaning basically the child is pretty much unconscious. They're not doing much at all and is on a breathing tube. There's bruising to the jaw and a swollen leg. The doctors there immediately get a CAT scan of the head and a skeletal survey. Mom comes to the ED and the boyfriend says the baby was fussy but denies any trauma. So if you work in this field, we've all heard this story a bunch of times. And so this child, it's a very close-up picture of bruising to the jaw just to orient you. There's a breathing tube going into some lips, and basically that's keeping the child alive. And then there's some tape to keep that breathing tube in place. And just beneath it on the jawline is some significant bruising, and you can see the arrow pointing to it. On the CAT scan, there's a lot of bleeding. Dr. Rabbitt's pointing to it now. It is what we call a mass effect bleed, meaning it's squishing the brain over. If you are in medicine, you know that this brain looks very, very sick and very, very bad, and there's a lot of blood in the brain. On the skeletal survey, there's a left femur fracture. And so the hip is at the top of the femur, and you can see the broken bone right there where Dr. Rabbitt is pointing. The other x-rays of the same bone, and you can see, as my friends that aren't in medicine would say, that just doesn't look right. The bone is completely broken in half. Child is otherwise previously well, had been meeting her milestones, walking well, has greater than 10 words, no history of any trauma, and no siblings in the home. So if we scroll now to head injuries and skull fractures on the app, again, you get the table of contents and decision-making tools. If you click on decision-making tools, we're going to get the opportunity to put in inputs. So what do we have here? We have a subdural hematoma. It's space occupying. Now, if you're not in medicine, I don't expect you to know that, but that's the sort of thing you could talk to the doctors about, and they could help you with that. What was the first ill symptom? It was abnormal breathing. When did this occur? We don't know. When did the child become impaired? Was today, and it's kind of cool. There's actually a clock on there where you type in exactly when the injury happened, as far as you know, or when they became impaired. What is that useful for? Like I said, there's a lot of complicated decision tree stuff behind this app that you don't see on the surface. Is the injury consistent with development? Well, we don't know because we don't have any injury history, right? There's no known injury history. And are there significant injuries to other body parts? Yes, because this child has bruises and a broken leg in addition to the head injury. There are no siblings, and the child is less than 2 years of age. So you put that in, and you'll notice that for head injuries and fractures and burns, the recommendations are a little bit different. They don't have that little dial on the top because the evaluation of these things is a little bit more complicated than bruises. Bruises has very fine-tuned data around it that head injuries don't. But you'll get the picture from the recommendations. And you can see there are next steps for investigators about photos, further injury history, interviewing all caregivers. For medical, it's all the tests that need to be run, looking for other trauma, also looking for medical conditions that are under consideration. And what that'll do is it allows all these tests that need to be done, hopefully will be done up front as opposed to having to catch them later on. And it tells the medical providers they need to discuss the findings with a forensic medical expert, and that this child will likely need a repeat skeletal survey in 2 weeks' time. And then underneath it, there's a bunch of related library content. So if you click on those, it'll take you to the animations for each one of those, so that if you're trying to figure out the difference between a subdural and a subarachnoid bleed, there's an animation that will show you exactly what that is using the inside of Chucky's head. There's also a link that comes up in the app in several spots about injury histories, and it takes you to the sheet, which really is a nice checklist for people who don't do this work on a regular basis to remember what questions to ask somebody. And you don't want to, these are the sort of things you want to get in a conversation from somebody. We're not asking somebody to go through and interrogate somebody with this list. But this is kind of the information like if I'm a child abuse doctor, or I am, and I want information, this is the information I want. And so you want to get this through a conversation the way you usually would with somebody. And then we use that in deciding if the injury makes sense. And again, this is embedded within the app. As I mentioned before, in this case, this child had cerebral edema and a subdural hematoma, and there are animations that can take you through what those mean, how they happen, and their relation to different types of injuries. There are CAT scans, MRIs of what those look like, and there's animations and descriptions of what it actually is that is going on within the child's skull. We mentioned on our skeletal survey, this child had a broken femur, and those are just the images that we kind of went through before. And so you could put in the information about the fractures as well and learn about those fractures. And this child had a spiral fracture of the femur, and it can take you through the animation of how that could happen, both accidentally or inflicted. And you can see there's all different types of fractures. And there's different locations. You can do the ribs, you can do your arms or legs, you can do specific parts of the arms or legs, and you can learn about dating fractures. How good are we at dating fractures, and what's the evidence behind it? All of this is in the animations in the app. So in this case, and in general, the Child Protector provides recommendations and guidance for medical providers and investigators. It does not provide a diagnosis. I cannot emphasize that enough. But it does give you guidance and point people in the right direction to get the initial stuff done well, hopefully, and then also foster communication between investigators and medical personnel. Obviously, if you have a complex or serious case, you want to access an expert and help them walk you through it. But at least in my experience with a lot of folks around me who use the app, it gets things pointed in the right direction so that when I get the case, the stuff I need is already there. So certainly medical diagnosis of abusive head trauma are concerned for it, triggers a multidisciplinary response. The tool hopefully can help those of you who are not medical understand what is going on in the case, understand the injuries, be more informed when you talk to the family and talk to the medical professionals, and help you be better at what you do, just like your work makes us better at what we do. And that is really the end goal of the app, because when we're better at what we do, we're able to help children and families more. There are two bad things I always say in child abuse. The first is that you miss abuse and a kid goes back home and gets injured again. And the other is that we overcall and that we think something's abusive when it's really not. And that's bad in its own way, and we don't want that to happen either. And the goal of the app is to minimize either of those happening. And I think we already talked about this. These are the overall goals of the app. And I would encourage you, if you haven't already, download the app and just mess around with it. Play around, put things in, see what you get out, apply it to some of your cases, and look at the videos. People who use it, I think, generally find it to be useful. It's never going to charge you. There's no money associated with this thing. It's a free app. We update it every few years and keep the information relevant and evidence-based. And when there's an update, you get a notification and it tells you to download the update. And that won't happen for a couple of years at the soonest. Again, it's free. There's a website as well, www.childprotector.app.com. It's got all the animations on there. So if you're doing a PowerPoint presentation, you can actually link to that website and show the video. Any of the videos on the app are on that website. You just need internet connection, and you can use it. It's free. We want people to use it, and you can use it as an education tool. My contact information is there at the bottom. Please feel free to email me, and I'll turn it back over to Dr. Rabbitt or Elizabeth for wrap-up.
All right, thank you so much, Dr. Anderst, for being here today and going through the app. This is something that we have integrated into education for all of our learners that come through our program, and they've found it really helpful. So I hope that it's helpful as well for investigators and providers that are on the call. And if you have any questions, I think we have a couple minutes. We can answer them now. Otherwise, my email address is up here too, and I'm happy to respond to emails.
We do have a question, Angela, and this was closer when you were talking about the system review. Would the algorithm include symptoms such as vomiting in a 2-month-old or other subtle symptoms of abusive head trauma?
That is a really good question. It's really based on physical findings at this point. We do try to do a lot of education for all our providers that, when you have nonspecific symptoms like that, you need to be asking more questions. In particular, even if you're not seeing any marks on the baby at that moment, is there a history of marks in the past of bruises or bleeding of the mouth? Because those are important and might make someone think harder about trauma as a potential cause of that. But the algorithm right now really only includes physical exam findings. And we will, physical exam findings, and if there are additional concerns like CPS has become involved, or law enforcement. But as I said, it's an ongoing, evaluation of this tool, and it might be something that we would add later if it seems to be important.
Wonderful, thank you. So that was the only question. The only other thing was a comment that the app is awesome. So thank you. I'll ask you to leave the attendance slide on the screen for a couple of minutes. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar, Sex Trafficking in Minors, Community Responses and Resources, presented by Rebecca Detman, Angela Rabbitt, and Maria Rosick. Thank you for being with us today.